All right. So today, as you know, changing our minds on psychedelics, can psilocybin, MDMA, and ketamine improve your health? Well, hang in there because Charlie's going to tell us. Next slide.
We have some great upcoming talks. I'm so looking forward to Kurt's on the next one and the Kratom update because I think everybody's seeing a lot more of that. And case reviews is also a super helpful one if you have folks in your clinic that want to learn more about how to do any piece or part of this and could use some case review to make it really practical and applicable. We're not going to have Echo on November 26th around holiday time. And if you want to check out other Echoes, feel free to look at the bottom of the screen for others offered and peruse their websites.
Yeah. And as I just mentioned, it's going to be about Kratom, and the special guest is going to be 7-hydroxymetragenine. We're going to kind of talk about that whole thing, which has just happened. The case studies, just so everybody knows, right now, I think I have 10 actual cases that we've had, and we're just going to kind of work through them, just what other people would do. There's really, as Charlie and I were talking about earlier, there's often not just one way to skin the cat. And as a cat owner, I say that jokingly. But I think that it's just really how we approach some of these cases, and whether we micro them, macro them, how we do them. So we did it once before and everybody really liked it. So we're going to do it again. All right, move on.
Oh, I think this is our next one. Just remember, we're always here for technical assistance, so don't hesitate to reach out if you need anything or need to run a case by us.
Yep, and again, you can go on the Center for Opioid Resources. There's all kinds of resources on there. Don't reinvent the wheel. Go on there and look around, see if there's stuff that might be helpful. Next slide. Oh, looks like we got a poll. Which of these best describes your role? Please punch that in so we know. And maybe you don't have a role. Just put other.
So was the cat comment actually a joke? I don't know that it was.
Yeah. Is that a poll? No, we have 3 cats. So yeah, you need cats in the country because you have varmints. All right. Looks like more providers than anything. All right. Next poll and last poll. Man, those don't come up the fastest.
All right. As part of your role, what applies to you?
And while we wait for the results of this poll, remember that Charlie loves to see your faces, so don't be afraid to turn on your video. It's much more fun for him to talk to a whole bunch of faces. So feel free to flip that on even if you're having a little lunch. No big deal. All right. Wow, that's really cool. All right. So with no further delay, we will move on to Charlie. And Charlie, if you want to kind of introduce yourself and kind of tell us a little bit what fun things you do down at Hennepin.
Yeah, Charlie Resnikoff. I do addiction medicine, inpatient and outpatient addiction medicine, and I do still hospital medicine, and I'm part of the internal medicine residency program. I'm an associate program director, and I was sort of asked to come up with this talk by the American College of Physicians. And so I came up with it, and I kind of had this date. Kurt and I had agreed that I would give a talk on this date, and I said, hey, how about we do this talk now? And he said, great idea. So that's kind of how this came about. Hey, Katie, should I share my own slides, or
if you want to? It's up to you.
Okay. I think it might be easiest for me to do that.
Okay.
So is it go time?
Yeah. Yep.
Okay. Let's do it. Okay.
Charlie, I'm not sure if you saw, but Cole did show up, so he's going to be
Oh,
the backup on this.
but is Beth here? Because if Beth is here, I'm gonna hear it.
Yeah.
I am definitely gonna hear it from her because she has corrected me more than any human alive, and she's usually it's deserving. So, are we good to go?
Go.
Okay, so a little bit of false advertising. There was so much on just psilocybin and ketamine that I didn't actually go into MDMA. So I know that's like this maybe a disappointment, but there is a lot on psilocybin and ketamine. And if it's well received, I'll come back and talk about MDMA another day. So why is there a rise in a demand for psilocybin and ketamine as therapeutics now? And what do we know about the harms and benefits of each? That's what I'm doing today. And it really starts with, let me do this. Okay. It really starts with understanding, I think, what's happening in our world. And that is that anxiousness, not anxiety, but anxiousness is increasing significantly since COVID. Young people are uncomfortable if they're not holding their phone, and 50% of them are actively trying to manage their phone use. And all of these sort of anxiety trends are most accentuated in young people. And young people are important for what I'm about to say. I think really interesting, there are more alcohol abstainers now since basically prohibition. Like that's incredible. There's more alcohol abstainers today since prohibition. And also, there's since maybe 2019 or so, on the right, you'll see a really remarkable increase in the perception that alcohol is unhealthy. And so both alcohol use has declined and the view that alcohol is unhealthy has increased. And I think really very surprising in researching this is that there are more marijuana, cannabis abstainers than there have been in a while. The trend is reversing. And the only category of cannabis use in this poll that is increasing is daily use among millennials, but every other category of use pattern and age bracket, cannabis use is decreasing. So alcohol and cannabis use is decreasing. And actually, I found this interesting. Cannabis use, negative health views about cannabis use are rising. So both alcohol and cannabis have rising negative health views and decreasing use patterns. And here's like a zoom out. The y-axis is not the same on these two, so it's a little misleading. 80% on the right, 100% on the left. But here's a zoom out. On the left is alcohol over time. And actually, you can see that men and women approximate towards the end there. And on the right is cannabis over time. And again, you can see that men and women are really overlapping at the end there. So women and men have kind of converging substance use patterns, which is also very interesting. And there's a little more about the alcohol. Alcohol sales are dropping 2% a year. And actually, that's accelerating. Like this year will probably be the worst yet. And the total revenue in America is $540 billion for alcohol. So just the loss of revenue on alcohol is like 5 times the total research budget on psilocybin. Like it's the loss of revenue is greater than magnitudes greater. And the loss of revenue on alcohol is magnitudes greater than anything that's happening with psilocybin or ketamine. I mean, it's huge what's happening in our country with alcohol, even though it's, 2% seems like not much. So why is alcohol going down? Wellness, health effects, people under the age of 40 are really leading this, but it's not just them, and cost savings. And so one more bit of, I'll call this very good news, and that is tobacco use is basically at its lowest point ever recorded. So that's incredible. Non-smoke tobacco like Zyn, which I don't show here, but also vaping nicotine is rising, especially among young people again. So here's the context. Stress is rising. Alcohol abstinence is increasing. Cannabis abstinence is increasing. Tobacco smoking is decreasing, thankfully, and non-smoke nicotine is increasing. Rising health concerns, coincide with these changes. So a lot of the above what I mentioned is like, I'm worried the substance isn't helping me. And that has created a demand, or even, if you will, a market for substances that can help manage stress, but are compatible with wellness. So, and of all this, people under 40 are leading the trends, except for daily cannabis use, but which they're still doing more of. But in almost all ways, they're leading the trends. So why psilocybin and ketamine? And I think there's a belief, and I'm not saying these things are all true, you judge for yourself, that there's a lot of things that really are exciting about psilocybin and ketamine, given that context I just listed. But they're very different. So think about ketamine as this like synthetic creation of industry used in war, literally. I'll tell you that in a second. Literally used in war. It's a synthetic and it is powerful. And psilocybin comes from a family of drugs that are basically found in nature, minimally altered from how they're found in nature, and not industrial, not used in war, not used in the operating room, but also are very powerful. So these are both powerful entities, but they're differently powerful. So psilocybin containing mushrooms, I just took these photos from Wikipedia, literally. They are found on every single continent other than our Antarctica. Okay, psilocybin is a psychedelic. And if you read a lot about this stuff, the terms psychedelic, hallucinogen, dissociation gets very loosely thrown about for all of these things. I'm kind of strict on how I categorize these things. A psychedelic, I don't use the word hallucinogen, but a psychedelic synonymous with hallucinogen simplistically boosts serotonin in the brain. And after boosting certain types of serotonin in the brain, it can create a sense of reward, but more importantly, mood elevation, sensory experience, spiritual or cognitive effects, a sense of connectedness to others or to animals, and increased sympathetic tone. So other psychedelics, interestingly, they all have, everything I'm listing have a natural analog. So ergot alkaloids are found, which include LSD, but they can be found in mushrooms. DMT, of course, is found as a tree bark in Brazil, et cetera. Mescaline is found in peyote. Ibogaine has a really complex mechanism of action, but it could be categorized as psychedelic as part of its mechanism of action. And then there are synthetic psychedelics as well. A hallmark of psychedelics is very rapid tolerance. So daily repeated use is pretty uncommon. Also, I didn't include this here, but another hallmark of psychedelics is they commonly cause dysphoric or aversive effects. So people, if you use psychedelics enough, you're going to have a bad trip. And the combination of rapid development of tolerance and aversive or dysphoric effects, among other reasons, makes addiction to psychedelics, let's say, very uncommon or just doesn't happen. So it's controversial at best whether addiction happens to psychedelics, and those are some of the reasons why. I differentiate MDMA from psychedelics. I feel like MDMA and so-called empathogens are sort of halfway between the psychedelics and stimulants. So I don't, but some people will put MDMA in this category. Use of psychedelics is for all people. Use of psychedelics is 4% ish, but young people are up over 6% have ever used. Past year use. And then I think initiates, if you exclude all the nicotine products and alcohol and cannabis, hallucinogens are the most commonly initiated drug. That's really impressive. Like, this is like fourth in line for what people are initiating, trying. So it's a really common, important drug to understand. Minnesota has pretty restrictive laws. I mean, obviously, psilocybin is a federally controlled, Schedule 1 controlled substance. So it's a Schedule 1 controlled substance federally. In Minnesota, small amounts are a misdemeanor and you can get a fine, like $200. Large amounts are a felony and up to 30 years in prison and $1 million fine. there is a Minnesota Department of Health psychedelic task force. They last met in 2024. I suspect that with a lot of the stuff going on in Congress, the joint control over Congress, state legislature between the Dems and the Republicans, a lot of these things got put on hold. But in their last meeting, they put out recommendations which would be for Minnesota to create a state-regulated clinical program for the therapeutic administration of psilocybin-containing mushrooms, remove criminal penalties for the personal use and possession of psilocybin-containing mushrooms, and allocate funding for more research on MDMA, psilocybin, and LSD. So I'll just editorialize that when I do the political math on this, so cannabis was legalized in Minnesota, I think, because 5% of people vote based on cannabis legalization. And the margin between the Dems and the Republicans was less than 5%. And that combination made it a certainty that the DFL was going to support cannabis legalization because they needed that 5% of voters who might otherwise vote for them, but are voting first and foremost for legalization of cannabis. I don't think there's 5% of voters that are passionately advocating as like a single item voting block to legalize psilocybin. I could be wrong, but I do think this will not happen until the Dems have full control. You call that good or call that bad, but I think that's reality. And I think even then it might not happen. I think there are people that have taken the temperature on what percentage of the voting public want this. And that will determine, it was deterministic with cannabis. There was just enough people who would otherwise vote DFL who wanted it that it had to happen. I'm not sure that's true with psilocybin. In Minnesota, it is pretty easy to get psilocybin from the black market. And you can literally Google, how do I get psilocybin? And there are websites. And I went down this pathway. And then you have to give up a bunch of your personal information, and I didn't want to go that far, so I didn't get too deep in. But you basically give your name and your phone number over, you text someone, you Venmo them money, and they have it shipped to your house. And I have many friends who have psilocybin products shipped to their house. And they Venmo, they give up, their identifying information, and they Venmo people money. And it's just very widely done. This is widely available in Minnesota through the black market. So what are the doses of psilocybin? I think 25. So first of all, psilocybin, the chemical, is basically only in research protocols. But then people will then use dried mushroom product, and there's 100-to-1 ratio. So that's kind of easy to remember. The research protocols all use 25 milligrams, and that's equivalent to 2.5 grams of dried mushrooms, right? If you're getting up over 25 milligrams, hang on to your hat. It's gonna be a wild ride. Over 50 is gonna be intense. At 25 is gonna be intense. But when you're getting up higher doses, that's a lot. Micro dosing for us, because of what we use the word micro dosing in our context, I think is a misleading word when it comes to psilocybin. Micro dosing is 1/5 to 1/50th of the therapeutic dose I just mentioned. So it's a tiny amount of dried mushroom. Like I said, 1/5 to 1/50th. There's a wide range, partly because if you're microdosing every day, you're going to accrue some tolerance, and the dose is probably going to go up. Also, this is really non-standardized. People report improvement in cognition, creativity, attention, mood. This is a dose that does not cause hallucinations, so you can go about your daily activities, and you don't need to have someone keeping you from wandering into the road. You can function somewhat, and people report benefits. The initial evidence on this is that it may be, the one trial I read is that they think it's a placebo on the one hand. The second thing I would say is the LSD microdosing trials. Actually, the people who receive the LSD are often aware that they're on LSD, so-called microdosing, because they feel more mood or energy. Their blood pressure and body temperature is measurably higher on these microdoses, but their cognitive performance doesn't change. So the LSD microdosing studies show mood, pleasure, blood pressure, temperature, and self-awareness that I'm on something, but not necessarily cognitive and not like creativity, et cetera. So the one thing I would caution with microdosing is that, one, it is usually noticeable to the patient. Yeah, they're not hallucinating, but they often know they're on something. And two, it's physiologically active. It affects blood pressure, body temperature, et cetera. So microdosing might be a misleading term depending on how we're thinking about it. But back to the big doses, the hallucination doses, 25 milligrams or more of psilocybin. The proven therapeutic benefit of psilocybin happens at those big doses. That's where the best research is. And this is like the timeline. So you're going to peak in your hallucinatory experience, et cetera, at 2 hours. And you probably need someone to be with you for 6 hours or longer if you're doing one of these things. The research protocols are 1 or 2 sessions, which is incredible because you'll see some of the results. 1 or 2 sessions, each session 6 hours or more, and you're getting 25 milligrams of psilocybin per session, sometimes up to 50, and you're hallucinating, right? The therapeutic benefit coincides, the proven therapeutic benefit coincides with a hallucinatory, profound psychedelic experience. You need 2 trained guides now because 1 trained guide isn't enough because you're so vulnerable. Both you could mistake something the guide does as inappropriate or assault, or a guide could truly assault you. So now you need to have 2 trained guides, and that tells you something about the vulnerability of someone in one of these states. It's important that they're safe. And then set and setting is this old-timey way of saying your environment has to be appropriate for having a psychedelic experience. Your mindset and your environment, you have to be prepared for this. And there's a preparation and debriefing in these trials. And then you will almost always, in the good trials, in the limitations, there will almost always be a sentence like what I quoted here, which came directly from a good trial of psilocybin. A limitation of the study is that nearly all participants and therapists correctly guessed the assigned medication in this double-blind randomized trial. In addiction medicine, it is really hard to blind our trials. And we talk about it's a controlled substance, being a Schedule I substance is a barrier to good research. And that is true, but that is not the only barrier. It is very hard to blind these trials. Everybody knows who's hallucinating. Like, it's not a secret. And so unfortunately, it's really hard to get scientific rigor when everybody knows who's hallucinating. I think it's important to be wary about neuroscientific storytelling. Why does psilocybin treat depression? Whatever. But nonetheless, here I go. I'm going to tell a story. Supposedly, psilocybin has been measured to increase brain connectivity. So that's one thing. And the second thing is, normally we walk around with a lot of top-down signaling, meaning my prefrontal cortex, my higher, cognitive centers have a set of expectations about what they're going to see, and I only see what basically I expect to see. So I have all these filters on my perception. I have cognitive filters on my perception. But in a psilocybin state, those cognitive filters are lifted, allowing perceptual inputs to be enhanced. So you are more open. You have a more openness to perceptual inputs, number 1. And number 2, connectivity has changed. And number 3, which I don't really demonstrate here with a cartoon, plasticity has changed. So you are open to perceptual inputs. There's greater connectivity in your brain, and your brain can be changed by these experiences. That's at least the story that is told. Psilocybin can enable lasting insights. I'm not going through all this, but serotonin is central. And I circled 5-HT2A because I'm coming back to it later. Psilocybin, most psychedelics actually, affect many of the serotonin receptors, but 5-HT2A is an important one. Psilocin is an active metabolite, and that's also being researched for similar outcomes. It kicks in quicker. So it might shorten the research protocol. So you might hear about psilocin as a shorter, quicker alternative to psilocybin. Okay, so this is a pretty short list, but if you talk about, I think, evidence that we can either act on or be hopeful about, I think there's really interesting evidence about treatment-resistant depression at 3 months, up to 3 months. And I think there's interesting evidence about alcohol use. So here's the New England Journal of Medicine article that showed treatment-resistant depression. And so you can see blue line is the 25 milligram dose. That's the most active dose. So it really takes a significant dose. And as early as day 2, but all the way out to week 12, there's the confidence intervals don't overlap. So there's a difference between those who got solid. So this is 2 sessions, and you got 12 weeks. And treatment depression, so let's read this quote. For participants in this trial, psilocybin therapy represented a 3rd, 4th, or 5th line treatment. These are patients who've tried a lot of things for their depression. The response at week 3, which is 37%, so that's a really robust, week 3 is their most robust response, in the 25 milligram group was numerically lower than described for first-line treatments for major depressive disorder. So what that means is, like, if you take all people with depression and give them an SSRI, they'll have better odds than if you take a treatment-resistant depression case and give them psilocybin. But that's not a fair comparison, as this study points out, but this improvement was higher than the incidences of response for a trial looking at second-line treatments. So if you take this psilocybin treatment for treatment-resistant depression and compare it to other treatment-resistant depression trials, it performs better than those trials. But if you compare it to first-line agents with the general public with depression, it performs worse. But it's an open question how psilocybin would do for depression as a first-line treatment. I don't think we know the answer to that, but I think it has shown its value for treatment-resistant depression in this trial. And the main adverse events were headache and nausea. Headache and nausea, those are important. And we'll talk more about some other adverse events. How about alcohol? So psilocybin plus motivational interviewing compared to motivational interviewing alone. They looked at 95 patients, 32 weeks. Their control group actually was Benadryl. So yeah, imagine expecting you're going to get psilocybin and you get Benadryl instead. Total snoozer. So anyways, 25 to 50 milligrams of psilocybin. But their outcome at 32 weeks was heavy drinking days in the control group, 23.6%. Sorry, I got these mixed up. 23.6 in the control group, 9.7 in the psilocybin group. So if that's real, it's a lot easier to blind a trial of naltrexone. That's a pretty easy double-blind trial. So this is not as strong of evidence, but if that's real, that competes with anything we got for medications for alcohol use disorder. So I think I'm excited by that. And again, these are two therapy sessions at pretty standard psilocybin doses, and it sustains up to 32 weeks. So, and there's a lot of other things that are worth being open to, but they just haven't been adequately. I don't think they're ready for prime time based on the evidence. End of life, depression, anxiety, there's some hopeful evidence. PTSD symptoms, hopeful evidence there. Tobacco cessation, those numbers are really low, and the evidence is almost not credible. I mean, like the quit rates are suspicious. Let me put it that way. Nobody gets quit rates from tobacco like that. And I mean, if it was true, it would be revolutionary. But I think you have to be skeptical of the tobacco until we see greater numbers in those trials. And there's an opioid cessation trial ongoing at the University of Wisconsin. Turns out it's really hard to bring a fentanyl user into a rigorous research protocol. So they've had a hard time recruiting patients. Here are the most important side effects. We'll talk about hypertension, nausea, headache, dizziness, and I'll talk a little bit about psychotic symptoms. And there's some other things I'm going to bring up as well. We don't need to go through all this, but just to understand that there's been some good research on which of these adverse effects come through in multiple trials as consistent adverse effects. And they're the ones I've already listed to you, but headache, nausea. Nausea is a really important one. That's clearly a side effect. Blood pressure elevation, heart rate elevation, and some cognitive changes. So psilocybin and hypertension. So I think the vast majority of people who use this are young and healthy. They can take it. No big deal. But if you're dealing with a frail older person, someone with complex medical issues, they are going to have a transient increase in their blood pressure and heart rate. So that's really important as we're talking, because realistically, I don't know that these clinics are going to exist anytime soon, because I don't know that the model is profitable enough. But I do think what might happen is we decriminalize psilocybin and use increases, and we're counseling our patients on what they want to do at home with their psilocybin. And if a patient has the cardiovascular risks, I would at least consider the blood pressure and heart rate changes that maybe pose a risk. A lot of these patients are already on serotonin reuptake inhibitors. They already have depression. That's why they're trying psilocybin. They think it might help, and it might help, but they're already on all these serotonergic agents. So what about serotonin syndrome? And first of all, antidepressants, for this reason, probably are held in psilocybin research trials. So we just don't have good research data on mixing psilocybin with SSRIs. There's been survey data asking people to use psilocybin who are on SSRIs, and 8% of them say it has altered. Sometimes they like the change. It has altered the effect of psilocybin for them to be on SSRIs, but that's really poorly conducted studies. It's a clear recommendation not to take psilocybin if you're on a monoamine oxidase inhibitor, a type of antidepressant that puts you at risk for serotonin syndrome. And there's only one case of serotonin toxicity on psilocybin that's published, and that person was on an MAOI. But what I would say is, like, if someone's going to a psilocybin experience and they're on these meds, they're on Adderall, they're on Imitrex for their migraines, they're taking these other meds, I would try not to have multiple serotonergic agents. I would try to pare it down or even have them hold their meds for the psilocybin trip. But that's just totally my advice, and there's not much evidence to support it. So I find this interesting. 1997, Mayo Clinic clinicians published a report of 24 cases of valvular disease in the New England Journal of Medicine, which resulted in a medication being pulled from the market 13 months later. Kurt probably remembers this because he was practicing medicine, I bet, at this time, and he probably had a lot of patients on this medicine in the 90s, loving this medicine, and then whoops, this medicine causes valvular disease. You can try to guess it, but for the purposes of time, I'm just going to keep going. And that medicine is fenfluramine, part of the fen-phen weight loss drug. Fenfluramine has the same mechanism of action, essentially, as psilocybin. Fenfluramine caused symptomatic aortic and mitral regurgitation. The prevalence was like 30% or more if you've been on this, and almost all women. And that may have been that more women than men were taking the medication, but almost all the cases were women. It was after 5 months of daily use of fenfluramine, and it happened in over 30% of patients. So this is not a trivial adverse effect. This was a big deal. And what happens is that these valves, shredded platelets, they always, in all of us, they're shredding platelets as the blood passes by these valves. And then when the platelets are shredded, they release serotonin. But if you also have a serotonin booster in your system at the same time as these platelets are getting torn up by their valves, the combination of those accelerated scar tissue on the valves. And you may be like, okay, I'm kind of out to lunch on this, but ergot alkaloid mushrooms cause valvular abnormalities. MDMA is associated with valvular abnormalities. Carcinoid tumors, which secrete serotonin, cause valvular abnormalities. So there's and all of these things have essentially the same mechanism of action of psilocybin. So I would be very worried about routine use of psilocybin, like daily microdosing. I would just urge people not to do it because of this. But that's all just conjecture. There's no cases of psilocybin-associated valvular disease in the literature. It's just the same mechanism. So what about psychosis? If you ask people who use psilocybin, 13% will describe experiences that are tolerable and frequent, and they return to psilocybin, and they're short-lived experience, but when they describe them, they are basically psychotic experiences. They are very similar to what people with primary psychosis will describe, but it's tolerable. There are a few case reports of mania, even suicide, severe psychosis. All of these case reports have very severe psychiatric diagnoses like bipolar, PTSD, and they're often taking exceptionally high psilocybin doses or mixing psilocybin with cannabis and other drugs. So I actually think the psilocybin will trigger psychosis. I think it's overstated. I don't think the literature supports it. I think, yes, you will have psychotic-like experiences, but it's pretty easy to weed out the people who have untreated bipolar disorder, PTSD, primary psychosis, and are mixing many drugs together. I mean, a lot of these so-called psilocybin issues, they were on methamphetamines. That was a common co-ingestion. So I'm skeptical of the psychosis literature. And so then the question, how do people die from psilocybin? It's very rare to die from psilocybin. But when you take reassurance from that, but at the same time understand we're talking almost entirely about young, otherwise healthy people, we don't have a big cohort of 80-year-olds taking psilocybin. So we don't know what a medically complex person, how they'll tolerate this. But most commonly, psilocybin deaths are from disorientation causing traumatic death. So they wander into the street. So if someone is with them taking care of them, they're much less likely to die from psilocybin. So in summary, for a medically healthy person without severe psychiatric disorder, occasional psilocybin is safe. And psilocybin therapy in a structured setting improves very resistant depression symptoms, significantly improves it. And I hope that psilocybin truly does reduce alcohol use, and other benefits may be on the way. But you can expect there to be hypertension, tachycardia, nausea, and headaches for 6 hours. I am skeptical of microdosing because it is physiologically active and it's of an uncertain benefit. So that's just a question mark. And remember, if you're really heavily, repeatedly using psilocybin I personally am going to warn people, daily use, don't do that. Like don't be the person who gets the valvular disease. So that's my psilocybin. I'm going to keep going to ketamine, which is a little shorter, and then hopefully, and I'm going to try to make there be time for questions. So ketamine was synthesized in 1962, FDA approved in 1970. It's used off-label and illicitly. It was preceded by PCP, phencyclidine, but PCP was so potent that it caused really disturbing dissociative states. And ketamine is more able to dose without creating a dissociative agitation. And so ketamine sort of took the role that PCP was originally using. And it was widely used in the Vietnam War as a battlefield anesthetic, because you can give ketamine, like basically anyone can give someone else IM ketamine and get good analgesia with a good safety profile. And then it's gone on to much more use since then. It's a Schedule III controlled substance, and it's basically every route it can be given. And I should say, nasal can be ketamine from a compounding pharmacy, or S-ketamine is an FDA-approved product. It is only nasal. S-ketamine is only nasal. Ketamine can be anything. It's got extensive first-pass metabolism. I'm not going to dwell on this because I don't think this is particularly strong. But at moral of the story, ketamine blocks NMDA receptor, and in effect inhibits inhibitory neurons. So ketamine inhibits inhibitory neurons. I got to wrap my mind around that. In so doing, it indirectly boosts serotonergic neurons that may help depression. It's also active in the dorsal horn, blocking sort of hyperalgesia and other sort of neuropathic pain and other types of effects that cause pain. So it's acting throughout the brain. It generally inhibits inhibitory neurons. But I need to work on my understanding of the complex neurophysiology of that. So what are the evidence-based indications? Obviously, anesthesia, evidence-based, FDA approved. Pain in the emergency department, acute severe pain, IV or IM, hospital medicine. We underuse it in our hospital, but the surgeons actually use quite a bit. The trauma surgeons at Hennepin have a lot of people on ketamine drips. And opioid-sparing analgesia, for example, in palliative care settings at the end of life, et cetera. Commonly, that's IV, PO. Chronic pain, I don't think it's a great idea for chronic pain, but it can be used for that. And it can actually be used intranasal, like from a compounding pharmacy. Treatment-resistant depression. So S-ketamine nasal, that's FDA approved. And IV ketamine clinics does not have FDA approval, but it's used evidence-based for the setting. Very controlled outpatient setting for those things. And then emerging indications, agitation, various withdrawal states, ICU sedation, and even things like status asthmaticus and status epilepticus. I don't understand that, but those are listed as emerging indications. So dosing, you will create dissociation with 1 milligram per kilogram IV or more. And that's going to be the anesthesiologist should be present for that. But you're not that far from those doses to get the treatment-resistant depression doses. So you're flirting with dissociation with the treatment-resistant depression doses with ketamine. So it's a pretty high dose. And then with acute pain, and this could be in the hospital, I think inpatient doctors could use this, as well as the emergency department, you're going to give an initial bolus and consider an infusion, depending on what's the issue. Like why you're giving it, you may switch to an infusion. And then for chronic pain, there's oral doses split throughout the day. Again, I'm not supporting that use, but those are the doses. And intranasal, I'm really not supporting that use either. Ketamine prescriptions have gone up. Red line is S-ketamine and black line is ketamine. So this is just Rhode Island, but ketamine prescriptions rising. There's a demand for this stuff. For treatment-resistant depression, that is the S-ketamine has the strictest REMS of any pharmaceutical today. Both patient and clinician have to complete a REMS. It is under tight wraps, S-ketamine, and there's a reason for it. I'll tell you in a sec. It's a highly controlled outpatient environment. You get supervised doses of IV or nasal, and then you get observed because this is close to a dissociative dose. So you really need someone there helping you, observing you. It's bi-weekly at first, twice a week at first for 4 weeks. And then off-label, this is not FDA approved, but off-label, there's often maintenance weekly after that. I have a friend who said this absolutely gave him his life back. I mean, he had bad depression. The wheels were falling off. And he compellingly told me, this changed his life. And again, this is, you squint at this, so let me just pause. I didn't put all the references, but I can get them to you later. With the psilocybin, it's like one interesting New England Journal article, right? Ketamine has 3 Cochrane reviews that support its indications. So ketamine is established. I mean, you have Cochrane reviews saying, this works within 24 hours for treatment-resistant depression to lower suicidality, to improve cognitive functions, to improve depression symptoms. So this has arrived. There's a Cochrane review on pain, and there's a Cochrane review on anesthesia. So this has arrived. There is not any doubt about it. So, but this shows you, suicidal thinking, depression, and cognitive function in people with resistant depression. These are people who really need help, and ketamine helps them. Pain. There are many, many ways. Ketamine is unique for pain, and there are many ways in which it can help pain, both nociceptive and neuropathic. It can prevent wind up of acute pain becoming chronic pain. It can interrupt opioid-induced hyperalgesia, and it can decrease opioid needs. There's evidence that adding ketamine to patients on high-dose opioids, for example, palliative care at the end of life, decreases their opioid requirements, and in fact can even decrease their opioid tolerance. There's a mechanism where ketamine decreases opioid tolerance. So this is pretty valuable. And I'll just give you one for us. We had a guy with a motorcycle accident who was on intramuscular naltrexone a couple of weeks ago at Hennepin. He needed some serious pain relief. He had polytrauma, and he wasn't going to get it from opioids. So that's the kind of person where ketamine is really valuable. But there may be other instances, high dose. Our palliative care team actually doesn't love ketamine because it causes a lot of sedation. So, but it can be used in these palliative care settings. It can be used in complex polytrauma, sickle disease on multiple opioids. You could consider some ketamine in a hospitalized setting. In an outpatient setting, be careful. I would just be careful about ketamine for chronic pain. I feel like I would really, really narrowly select my patients for that because of a lot of the risks that ketamine have, which I'll share in a minute. And which gets me to, I think, a really troubling trend. As awesome as I think the evidence is for ketamine for pain, depression, obviously anesthesia, there's now this like market of telehealth clinics and compounding pharmacies. And it's basically like the telehealth, FDA regulates what pharmaceutical makers can say, but the FDA does not regulate what a telehealth clinic can promise. So telehealth clinics, and just Google this, they're saying ketamine can treat Lyme disease. Literally. And they're making totally unsubstantiated, unregulated health benefits claims. And they're basically offering low barrier outpatient ketamine prescriptions. They will charge cash and you will get a home delivery of ketamine. So it's like basically, it's like back in the old opioid pill mill days. And the DEA and FDA, I mean, I know this is on DEA's radar, and the FDA really should be better marketing it. And to make matters worse, compounding pharmacies are taking these pills of ketamine and turning them into intranasal mist. Remember that, I'll talk about that in a second. And sublingual, basically lozenges. So they're changing the pills to a more rapid onset to avoid first pass metabolism. It's very troubling, I think, what's happening with telehealth visits and compounding pharmacies, giving ketamine to whoever wants them. So ketamine side effects, dizziness, nausea, headache, blood pressure. Am I ringing any bells? A lot like psilocybin, actually. But then we got dissociation, which is different from what happens with hallucinogens, I think. And we'll get to some of the other side effects. Just like with psilocybin, someone going into one of these ketamine clinics, they're going to have hypertension and they're going to have tachycardia. So our job is to make sure they're ready to tolerate a little stress test, with their heart rate. If they have angina, cardiovascular disease, it's not a good idea for them to do this. That's a relative contraindication. Uropathy, famously in the news, uropathy recently. Pretty common if you are exposed chronically to ketamine. I mean, pretty common that you're going to have a form of uropathy, and 51% improve. I don't know, 49% don't improve when you stop ketamine. And there's a lot of consequences of chronic ketamine exposure, including urinary tract disruption, a variety of things. Hematuria, dysuria, urgency, and then also sexual dysfunction. For people who use daily ketamine for more than 3 years, I think this is the highest, is the stage 3 group. They have abnormal renal function, abnormal liver function, their bladder doesn't work anymore. This is not something you want to be chronically exposed to. It's just not a good idea to have ongoing use of ketamine. Ketamine is addictive. Historically, it's been, nightclub going men, more men than women, young people going to nightclubs, taking ketamine in urban settings, often mixing with other drugs, and they do get use disorder. Nasal is the route of choice for addiction. So that is why giving outpatient prescriptions of compounded nasal mist is very fraught. This is how people get addicted to ketamine, is nasal insufflation or nasal mist. So Rates of ketamine misuse have been rising. And we'll just forget this last bullet point. It's a little incomplete. But lifetime use of ketamine in Americans is only 4 million. So not a super common drug, but it's rising. It's snorted. That's the nasal route. And it has historically been in young men who go to nightclubs, but it may be expanding outside that demographic. What about ketamine fatalities? If you look at drug-related fatalities, less than 1% of them involve ketamine. So this is not a major cause of drug-related fatalities. And of the, I think there's more than 900 deaths described in this Morbidity Mortality Weekly, only 24, 2.6 of the ketamine-involved fatalities had only ketamine. 2.6%. 97+%, they've got other drugs on board. Meth, cocaine, benzos, opioids, alcohol, and it's really the other CNS depressants. Ketamine is not on its own much of a respiratory depressant, but if you mix in other CNS depressants, it can be pretty bad. So what does that mean? I mean, there are fatalities, don't mix it with other drugs, but as fatal overdoses go, not the commonest cause of a fatal overdose. So here's my adverse effects. Acutely, hypertension, tachycardia, nausea, etc. And then chronically, uropathy and other organ malfunction like liver failure, abdominal pain, the K cramps is what they're called. Chronic exposure to ketamine causes K cramps, and chronic cognitive impairment from overexposure, attentional impairments, overexposure to ketamine. So when I summarize ketamine, I would say ketamine is integral to healthcare as an anesthetic and an analgesic. And there is a really important role for treatment-resistant depression. And there are many other important emerging indications. But keep in mind that ketamine is addictive and has serious adverse effects and is potentially fatal. And I would say the most worrisome for me adverse effects come probably from chronic repeated use of ketamine, although overdose mixed with other drugs is possible. So I think my take home with ketamine use is to really consider the context of use to optimize the risk benefits in a controlled setting. I think ketamine is really a wonderful agent, but in like low barrier telehealth visits with compounding pharmacies and nasal sprays, boy, I'm worried about that. I don't know that those telehealth visits are monitoring and educating for safety and talking about uropathy, et cetera. And then black market use in nightclubs, I mean, that's going to be a little more fraught. Obviously, that's going to be more fraught. So then in summary, psilocybin, a psychedelic, ketamine, a dissociative, psilocybin, serotonin, ketamine, NMDA receptor antagonist, psilocybin, hallucination, confusion, panic, nausea, vomiting, dissociation, emergence phenomenon, the agitation, also, I should say nausea, vomiting as well. Psilocybin increases sympathetic tone, might cause serotonin syndrome. Ketamine increases sympathetic tone. If I haven't already mentioned it, ketamine should not be co-administered with monoamine oxidase inhibitors as well, although the literature on that is it's not like there's a bunch of convincing cases out there of ketamine serotonin syndrome. I'm worried about psilocybin causing valvular disease, but that's me speculating. Ketamine definitely causes neuropathy and liver injury if chronically exposed. These are folks that are vulnerable and they're at risk of injury in both cases. Psilocybin is not addictive, ketamine is addictive, and there are overdoses in which ketamine is on board at the time of death. Psilocybin Schedule 1, ketamine Schedule 3, psilocybin no FDA approval, ketamine FDA approval for anesthesia and depression. That's it, is there for FDA approval. But psilocybin has uses for treatment-resistant depression, addiction, and recreation. Obviously, that's not evidence-based, it's just used for recreation. And for ketamine, it's treatment-resistant depression, pain, and recreation. Psilocybin's oral basically is the only route normally. There have been case reports of injection, not a good idea. And ketamine, any route. And psilocybin is still really extra legal or research protocols. That's it. That's how you get psilocybin in Minnesota, whereas there are a lot of routes to get it if you want ketamine. Okay, people want to enjoy themselves and have mental health relief with minimal health consequences. I think that is the demand. And I think into that void, psilocybin and ketamine are entering, but that doesn't mean, and I think there are some benefits there, but there are some risks as well. Okay. That is all. I want to hear if there's questions.
Yeah, I'm just looking in the chat. Don't see anything yet. Did people want to unmute and ask questions?
I'm wondering if Dustin is referring to pasties or psilocybin.
I think he was referring to pasties.
Okay. I will share one thing that in others may. I've heard it said the difference between a psychedelic and a dissociative. A psychedelic is like you are watching a terrifying movie and you can't close your eyes and you're stuck watching something scary. But you are self-aware, you have insight, you know you took a medication causing this. A dissociative state is like you are trapped in the movie. And it's like a weird French art film. You don't know what the hell's happening. Excuse me for saying that. So a dissociative state, so a psychedelic state, you can enter the room and reassure the person. A dissociative state, you are just another scary hallucination. Going in the room and trying to reassure someone on PCP that everything's going to be okay is not going to help. You're just more stimulus that they can't make sense of. So hallucinations, they have insight. You can engage them. You can talk them down. You can reassure them. A truly dissociative state is you can't just walk in the room and talk them down. You're just another scary stimulus to them. Okay, I see some questions here.
Yep. A little something from Yolanda saying using it very commonly with withdrawal management.
I know that Cole taught me about that as well. Oh, there he is.
Do you want to just unmute Cole and just talk?
Yeah, I guess Charlie, that was awesome. So a couple questions I have is I use it like all the time in the hospital. And I guess one of the things I view it as is like the side effect profile is like, of all the medications, like this has the most dose dependent side effects of any medication or drug I've encountered. Like at low doses, insanely safe. Like those side effects, like I used only low dose and ketamine all the time. I have yet to see it cause sedation unless there's like, heroic doses of opioids that are also being used, because it potentiates those downstream effects of opioids. But I've never seen it cause sedation at low doses. I've seen it cause some nausea, but that is it. I mean, the big thing I worry about is dissociation. And usually the second patients experience that, it's like horrific and they never want to experience it again. And so that stops immediately after ketamine's withheld. So I guess one thing I would just like to point out is like compared to like giving someone Dilaudid, which is, going to put someone to sleep and stop someone from breathing, which we give out like candy in the hospital. I mean, the side effect profile for ketamine is I would view as way safer than even getting someone Dilaudid, like low dose ketamine.
Our hospital medicine colleagues, I think, are underusing this at Hennepin, but our trauma surgeons are now routinely using ketamine infusions for complicated cases.
Yeah. And I use the same IV formulation, except give it orally because I can get it anywhere in the hospital. Like kind of oddly, liquid. Yeah, kind of oddly, they're really restrictive about where it can be given because it's used as an anesthetic. But I mean, we give Dilaudid all over the hospital. Again, low dose ketamine is not going to have any of those risks. But the oral solution that palliative tends to use most, I can give anywhere, and it just adjust the dose. So is
this all in acute settings, or do you any chronic ketamine, or how?
I've only done it in acute settings, like in the hospital, or like short term perioperatively for a week or two, because insurance never covers it. It has to be compounded, but it's relatively cheap out of pocket, at least at the compounded pharmacies up here. And like the other thing that I like mechanistically, and as far as I know, there's like no legitimate withdrawal syndrome from ketamine, or any dextromethorphan or any NMDA antagonist. So that's the nice thing too, is like you just continue it and then you can stop it, 3 weeks later if they're on it for acute pain or after a trauma. So just wanted to say that, like, in regards to this, so like the safety profile, like I view it as like really safe compared to like what we typically give.
Yeah, that's all. Thank you for saying that. I mean, I am, as you probably heard, I am worried about low threshold telehealth visits where the patient doesn't get a proper medical evaluation. They just get
totally. Yeah,
absolutely. I worry about that because that's just so, like ready for exploitation. But I also, there's a lot of benefits to ketamine.
Charlie, it's interesting you say that too, because in the addiction clinic, I can tell you that patients find ketamine telehealth people, and I have many patients who are in the process of trying it for all kinds of different things, which again really scares me. I don't, it's not regulated really. There's no records to get. I don't really know what they're doing, but people reach out to these telehealth places. So yeah, I would agree with that.
There's a question for Cole in the chat. What dose do you use of your ketamine? Your PO dose. Oh, there you go.
Yeah, it depends upon your solution, whether it's diluted or not. Like we just administer tiny amounts. So roughly the calculation is I won't go into the details, but roughly the calculation with the bioavailability orally, it's around 10 to 40 milligrams TID to QID. And I think I've maybe caused, dissociation / hallucinations and maybe, I don't know, 3 or 4 patients that have stopped like after, and goal is not to cause it, but it stops immediately after I stop ketamine. Yeah. And they'll let me know because they're horrific usually.
We use ketamine a lot for our patients that have treatment-resistant depression and have seen amazing results from it. So just like up here. So like that I believe in. Also with PTSD symptoms, I know there's more research coming out about that as well for the ketamine. And then the psilocybin as well, which I'm really interested about because the research that I've read about is giving really good results on that for like PTSD, depression, and stuff like that. So, which is really interesting to me. But I do recommend ketamine for anyone that is like treatment-resistant depression or really bad PTSD because it does help quite a bit.
Got it. Reading about it definitely changed my mind on the value of ketamine, for sure.
Charlie, in your talk, I know you said like in outpatient settings, this isn't used as much. I'm just wondering about like carceral settings and if you did have 24-hour nursing staff, if this would be a much safer alternative if you had a patient that came in taking a full agonist opioid that was maybe post-op or in need of pain management. Is that too risky to do this in a jail low dose? Or like, what are your feelings on that?
I'm not sure. I don't. That's an interesting idea. I don't know.
Cole kind of like popped that question into my head. It's like, okay, well, benefit maybe outweighs risk, and it's safer and less diversion potential than a full agonist opioid in that setting, maybe.
I think I would consider them equal diversion. I would assume that if someone could divert ketamine in a carceral setting or opioids, they would do it either way. I mean, I think the same person who would divert one would probably divert the other. I don't know. Maybe I'm wrong on that.
I guess the other thing with a carceral system, curious your thoughts, Charlie and Aaron, is like the last thing I'd want is someone in jail or prison having dissociation and like going into the K-hole and swinging at everything in sight.
Yeah.
That wouldn't be the case with opioids.
Right. Just the respiratory depression you worry so much about. Yeah, it's just a sticky wicket, and we're seeing it more and more often now in jails, higher acuity of patients. And what do you do in that scenario? What's best for patient safety?
I don't know. I would probably, given the choice, I would probably see how much I could lean on buprenorphine rather than, I mean, just better safety profile. And yeah, that might be what I did it rather than ketamine. Okay. Are we good?
I think we're
That was
good.
awesome.
I didn't
That was
tell any
awesome.
stories from college, not one.
No, Charlie, that was a fabulous talk. Really appreciate it. And thanks, Cole, for coming on and chatting. So really appreciate the talk and come back all the time, Charlie.
Okay. Thank you.
All right. We'll see you guys later. 2 weeks, kratom, and special guest 7-hydroxymetragine. So be a fun talk.